Hi, my name is Carol Poole. I'm a psychotherapist in Seattle. I've been practicing for about 20 years. And for the past 2.5 years, I've also been learning a lot about long COVID. The motivation was very personal. I have one of the milder cases of long COVID compared with a lot of people, but it's still no joke. But one of the things I've learned about it is that there's a large need for mental health counselors, along with the rest of the healthcare field, to get better educated about long COVID. Specifically, we need the information that allows us to support people by understanding that their illness is real and physical. We need some idea of how and when to offer referrals for medical health care and how to support people in navigating the healthcare system. We need to know which long COVID symptoms can easily be mistaken for depression and anxiety, but won't respond to anything but physiological treatment. And we need some understanding of what the major mental health consequences of long COVID are. So I'm offering this video as an in-depth introduction to long COVID for mental health professionals, long haulers, and anyone else who's interested. Thank you to the Northwest Alliance for Psychoanalytic Study for sponsoring this video. First, I want to recommend a fantastic resource full of nuts and bolts information about long COVID. It's called the Long COVID Survival Handbook, edited by Fiona Lowenstein. To be clear, I have no connection with this book myself, except as an appreciative reader. I'm recommending it because it's the best resource I know of. This book comes from a collaboration between patient advocates who have been doing solid, difficult, and largely unpaid work, most of them while being ill themselves. This book has been vetted and endorsed by leading researchers and journalists. It's a labor of love, and it's also quite sharp and cutting edge in its content. So I hope you'll give it a look for everything from lists of long COVID support groups to advice on navigating disability insurance, to descriptions of long COVID symptoms and research into its causes and possible treatments. The afterword in this book, I'll hold it up again, is by one of the world's leading long COVID researchers, Dr. Akiko Iwasaki, who leads the Iwasaki Immunology Lab at Yale University. I also recommend a video featuring Dr. Iwasaki, available for free on YouTube, titled Long COVID, a Parallel Pandemic. The video gives a sobering, realistic view of just how severely disabled many people are with long COVID, because the most disabled people are invisible to public view by virtue of being homebound. Those of us who work in healthcare need to know they exist, and not in small numbers either. How to tell what's true is an ongoing focus of study and practice for any psychotherapist. Those of us who have psychoanalytic bent may have many theories to help us discern the difference between knowing reality and defending against it. If you'd like to stay for the rest of this video, I now want to share some thoughts about how Wilfred Bion in particular helps me sort out what's true and what probably is more of a defense than an insight about this pandemic. We're in a strange moment. You can't work with SARS-CoV-2 in a lab without protective gear. But in most areas of daily life, we've stopped masking. Science has learned a lot about how to prevent this virus from spreading and mutating, but we aren't implementing what we know. For example, we're not introducing germicidal UV and better HEPA filtration and ventilation into schools or other critical public spaces. We're not pouring resources into nasal vaccines, which could protect much more effectively against infection and spread. Our current vaccines do a good job of reducing severity of illness, but they do not stop people from getting infected or keeping the virus in active circulation. Early in the pandemic, we were all following the same rule book, more or less. At least there was a single rule book to either follow or reject. Now it seems to me we live in parallel realities. For some of us, COVID is over. For others, it's anything but. Yet I don't think it's really a matter of opinion. We have facts. The individual risk of dying from any single case of COVID has come way down, but overall deaths remain high, because we've cut back on community precautions. And millions of people, anywhere from 5 to 50% of people who have had even mild cases of COVID, depending on the study, develop symptoms that go on for months to years. According to a CDC survey taken this past June, 1 in 13 Americans had long COVID, which is an umbrella term for several apparent subtypes of long-lasting COVID-related illness. For some, long COVID means feeling awful for a few months and then recovering mostly or even fully. For others, and we don't yet have solid research to tell us how big these subgroups are relative to each other, but for others, long COVID appears to be a chronic and potentially degenerative condition, maybe similar to an autoimmune disease or a neurological disorder such as MS. As mental health providers, we are probably already seeing at least some forms of long COVID in our practices. But long COVID is largely invisible, even to many who might be experiencing it themselves. I think people are afraid and ashamed to talk about it. Those of us old enough to have been here for the early years of the HIV/AIDS epidemic in the 80s may remember how chaotic it felt and how profoundly unsettling. Alarming inaccuracies and half-truths spread like fire. Some people reacted by ramping up their risks rather than feel defeated by a virus that seemed so fused with hostile prejudice. Governments did strange things for political reasons, as did some researchers, while a so-called church protested funerals in an effort to stigmatize and marginalize the dying. In hindsight, these reactions appear to have something in common. In the sense that Wilfred Bion developed in his psychoanalytic theories, they are ways of not learning from experience, of rejecting the unwanted reality by pretending that it either doesn't exist or it doesn't affect oneself. In his book, Learning from Experience, and other writings from the same period in the early 1960s, Bion articulated a sense that we learn through a dynamic interchange with each other in which the raw material of our experience can be contained, thought about, felt, and transformed into meaningful learning. He used the letter K to denote a particular kind of link between people, a link of knowing together. In the intimacy of psychoanalysis, he looked for signs of K as a dynamic of shared knowing. Or alternately, K could be blocked, resisted, defended against, a condition Bion thought of as negative K. When people are afraid to know, or when the conditions that foster shared learning from experience aren't available, then we see manifestations of negative K, a turning away from the experience that is felt to be too hard or too dangerous to try to learn from. When it comes to COVID, we seem to be in a moment of collective negative K, or at least I find myself turning to this concept of Bion's for help in analyzing some larger sense of community dynamics. We no longer keep track of cases. We lack coherent ways to share scientific understanding of a rapidly mutating virus whose ground rules keep changing. Our policies diverge widely, depending on whether they're based on science or political considerations. We don't link cause and effect. Hospitals are over full again, as it happens right now, particularly children's ICU units. The pandemic's direct and indirect impacts on the healthcare system continue to be brutal. But even when the common symptoms of COVID appear, they may not be recognized as such, since aren't we done with all that? A sketch on the comedy show SNL early in November depicted COVID as a product being recommended by doctors. Are you tired of working so hard? Try COVID. You can take 10 days off work and catch up on Netflix. It's a very different moment than late January 2021, when the newly elected President Biden and Vice President Harris stood before the Lincoln Memorial reflecting pool in ceremonial remembrance of those who had died to that point in the pandemic. It seemed a powerful collective moment of turning toward reality together, feeling our losses so we could begin to grieve them. But as Bion understood very well, learning from experience is never done, and reality often feels too big for our psyches to confront. Negative K is an ongoing mode people resort to whenever we feel overwhelmed or isolated, as I think many do right now when it comes to COVID. Yet the history of HIV and AIDS in this country includes many productive and ongoing efforts to learn positive K in action, starting with the movements in the earliest epidemic years to organize and push for research to develop the treatments we have today. And scientific learning over time, boosted by the political organizing of patient advocates and their allies, also increased a sense of collective understanding that helps contain anxiety. As therapists, we receive trainings about HIV and AIDS. A friend and colleague of mine often says she wants such a training about COVID, which would include solid clinical information about its persistent and potentially chronic manifestations, known as long COVID. I wish, too, that we had that quality and depth of understanding about COVID. Right now, the CDC and the World Health Organization don't even agree about everything. I'm not saying that to denigrate either institution. I'm just saying we're in a moment of chaotic retreat from and even attacks on learning. It's confusing. I can't offer the kind of clarity based on universal scientific consensus and protocol that my friend is looking for, but I can offer what I have learned from 2.5 years of paying very close attention and doing my best to discern positive from negative K. So I want to close by highlighting a few key takeaways from the research you can find documented and fleshed out in resources like the Long COVID Survival Handbook and Dr. Iwasaki's educational video on the parallel pandemic. Hallmarks to keep in mind as possible signs that a patient may have some form of long COVID. 1, the symptoms will be new. 2, they will probably be in some way weird, different from what they're familiar with or from known syndromes. For example, if a patient has a new onset of bad headaches, that might be accompanied by swelling in their hands and feet, visibly bulging blood vessels, or skin rashes. Weird in quality and in combination. That's how COVID often appears. It's a difficult choice as a therapist, whether or not to mention that you're wondering whether a symptom could be COVID-related. I think it's probably best to follow the patient's lead, respecting that some people find the topic traumatic right now. But we don't have to say the word COVID. We can simply say, you seem to be having some new symptoms. I think it'd be good to get it checked out by your doctor, as well as continuing to let me know how you're doing. One problem, though, is that we don't yet have a ton of long COVID-informed doctors to refer to. Here in Seattle, the best starting place, in my opinion, would be the UW Medicine's Long COVID Clinic. Doctors and staff at the UW Medicine conduct weekly group consults as they seek to ramp up their learning about long COVID, so patients benefit from that collaborative approach. Most long haulers I know, including me, find naturopaths and other complementary practitioners very helpful, as they often are for other poorly understood chronic conditions that standard medical practice may not know how to identify or treat yet. Personally, I've been helped by the Institute of Complementary Medicine in the Central District. Acupuncture is another field working hard on learning to treat long COVID. Long haulers need their therapists to accept that their illness is real. Unfortunately, long COVID, like other multi-system conditions, which are chronic rather than rapidly progressive, suffers from neglect in a medical system which really excels at problems that can be compartmentalized and cured. The best research we have so far suggests that the root cause of many, if not all, forms of long COVID might be viral persistence in the body, in reservoirs or in fragmentary proteins. Either way, people with long COVID aren't infectious. but their bodies might be suffering from an ongoing internal war between viral remnants and an increasingly exhausted and dysregulated immune system, which gets tricked by this particular virus into attacking the body's own cells instead of the virus. This ongoing war appears to cause damage to the endothelium, the inner lining of blood vessels, and also produces microscopic blood clots, which can clog capillaries and impede oxygenation, even when the large vessels are working well enough. One source of possible misunderstanding between doctors and patients is that exercise is generally found to be very helpful for people's recovery from many kinds of illness, but long COVID, or at least a major subtype of it, appears to be an exception. Fatigue is the most common long COVID symptom, and long haulers often report that it is weirdly awful fatigue, heavy, debilitating, which is made drastically worse by trying to push through it or exercise much at all. This form of long COVID appears to possibly resemble myalgic encephalomyelitis, which has also been known as chronic fatigue syndrome. The CDC, the World Health Organization, Britain's leading health standards body, and Mount Sinai Hospital in New York are among the authorities who have come around to accepting that post-exertional fatigue, in the sense of people getting worse from exercise, is a real physiological problem. But many doctors are still trained to review reports of post-exertional malaise with extreme skepticism and to see patients as psychosomatically ill, anxious, or depressed when they report that exercise is making them worse. Therapists can help by being educated about the difference between depression, which is helped by exercise, even though patients may need support to try it when they're feeling unmotivated, and post-viral fatigue, which may well be caused by metabolic or circulatory disorders. Another common symptom of long COVID is dysautonomia, or a malfunctioning of the autonomic nervous system. Patients with post-COVID dysautonomia may present with new symptoms that could be confused for panic or other forms of anxiety. Many long COVID patients have problems with tachycardia or abnormally fast heart rate, which can take different forms. Dysautonomia can also interfere with a person's ability to sleep, to breathe while asleep, or to tolerate changes of temperature. One way to try to suss out the difference between panic and long COVID is to pay close attention to whether or not the person also has a new problem tolerating warm, sunny days or hot baths without going into tachycardia. Doctors are often trained to view a vigilant attitude of closely monitoring apparently minor symptoms as pathological in itself. It's natural that our medical system reflects a larger societal value which normalizes an attitude of pushing one's body hard and not being overly in touch with it. I was reminded of this norm during the wildfire smoke season in October here in Seattle, when I saw some of my neighbors out running on hazardous air days. These attitudes compound with racism, sexism, and classism. Patients of color, especially Black and Indigenous patients, generally have a harder time being taken seriously when they report pain. So do women and gender nonconforming people. Just this morning, I saw a study come out confirming what common sense says is most likely true, that people of color are suffering worse from more severe long COVID. My own sense of long COVID is that this virus can set off a number of vicious cycles in the body. Treatment is about interrupting the vicious cycles so the body has a chance to heal. The treatments long haulers seem to find most helpful are all cycle disruptors: anti-inflammatories, antihistamines, antioxidants, anticoagulants, antivirals, and rest. Resting as much as you feel you need to is highly recommended. Yet the very essential workers who have taken on the biggest risks for all of us are so often the least protected, the least resourced, the least secure, and the least able either to afford expensive alternative medical treatment or to take time off when they need to rest. These inequities should trouble us all and demand answers. For anyone who experiences chronic illness, which can be managed but also can get out of hand and potentially become quite disabling, I would argue that it's actually adaptive and healthy to pay realistically close attention to signs that can help keep things on track. The way you would if you had a beautiful old house with a termite problem. You wouldn't ignore it. You'd keep an eye out for signs of a chronic problem kicking up again. During my own long COVID odyssey, it has helped that my own clinical support system, mainly my personal therapist and my longtime clinical consultant, both saw me as credible, realistically concerned about my health, and deserving of being taken seriously in both my perceptions and my needs. This kind of support helped me work throughout my illness and effectively find good medical care, with the inevitable trial and error involved in seeking the right treatment for a poorly understood new condition at a time when healthcare systems are under great stress. So long COVID patients, whether or not they think of themselves as such, need therapists to stretch in a countercultural direction, to value some of the unique perspectives and lessons offered by chronic multi-symptom illness, and not to psychopathologize what is really physiological. However, there are psychological and psychosocial impacts of long COVID too. One is that, as a neuroinflammatory condition, long COVID does often worsen pre-existing mental illness, such as bipolar disorder or psychotic disorders. A piece of possibly good news is that it appears that commonly prescribed psych meds, namely SSRIs and SNRIs, may be very helpful for post-COVID inflammation and circulation in the brain. These medications are potent anti-inflammatories, which can also improve blood flow in the nervous system, both very important goals with long COVID. Existentially and psychosocially, long COVID can be very depressing and can genuinely cause anxiety and PTSD. Many with long COVID lack adequate support. Some are abandoned by partners. Some lose their jobs and housing. Some are suffering from a severity of chronic pain that makes it inevitable to think about suicide. And indeed, the risk of suicidality needs to be carefully kept in mind as an element of the more severe forms of long COVID. The handbook I recommended has some good resources to offer to help patients rebuild their social support networks. As a final remark, I want to make it clear that the realities of long COVID can be hard to face for obvious reasons. But in facing them together, we have the opportunity to learn from this hard experience, the way Bion thought about learning. We can use thoughtful relationship as a container for working our way toward useful, meaningful understanding. My own hope lies in our ability to learn how to more effectively cope with this virus. I believe we're in trouble with it, but we can invent and learn our way through this trouble, and without leaving anyone behind. Thank you for tuning in. Please share this video with anyone you think might find it helpful. If you are a long hauler yourself and you have feedback for me, please get in touch at cpoole@carolpool.org. I know it's possible I've overlooked something or gotten it wrong in terms of your experience, so I do really welcome all feedback from people who know. Okay, thanks again for listening.